look familiar to me. Like, I don't know where we met before, but like, I feel like.
Oh.
Yeah.
Yeah. Actually, you look familiar too. Maybe in one of the meetings that Saba held or Sama. Have you attended any?
I've never been to anyone before, so probably in Sudan or something like that.
Maybe. But not nice knowing you. I'll scratch my head and try to remember. You know.
Yeah, I'm waiting for Dr. Osama. He's gonna present the first part, the chronic renal disease today.
Fair.
Yeah, supposed to be like for Dr. Alwali, but he's driving from Michigan to Ohio right now. So he gave the material and everything to Dr. Osama, and he's gonna present today, inshallah.
Excellent. Good.
Dr. Nader, I just want to see and ask your opinion. I would like to do a research in illicit drug in elderly population, because I have seen cases during my psychiatry observership of patients who's above 60, two of them, they try to commit suicide and they're serious in it. It is not like, you know, for sure. And they're very serious. So one, he almost about to get died, but they rescue him. So in the main point of that they have a severe back pain and they take opioid. And then they found themselves that the opioid is not working, and the doctors, they trying to, you know, reduce the doses. So they shift to another drugs that can relieve the pain. So I think this topic, even I'm trying to find the literature around this, I didn't find anything about the illicit drugs that elderly population use, like methamphetamine particularly, and heroin. And it is prevalent. Your voice, doctor.
Salam. Yeah, it's a good idea. Yeah, it is. And more and more we will find more people, because older people nowadays, they went through the early addiction part, or they have some exposure, not like the older population. So this subject will be something discussed in the near future, or you will have some research. So it's a good idea. I think it's a great idea. If you want to, we can discuss after the meeting.
Yes. Yeah, just.
Assalamu alaikum, everyone. So today we will have a great meeting. Hopefully everyone will show up. If not, please review the recording when you have a chance. Dr. Mazin will be leading the Zoom meeting. And, wish you all the best. You can start, Mazin. If Dr. Osama is available, that's fine. If not, we can skip the first part. We can do it later. Okay. Thank you.
I'm waiting for Dr. Osama to confirm with me right now. Dr. Osama?
I'm here, yep. Hello?
Are you ready for the part one, the chronic renal disease?
Yes. Did you hear me well?
I hear you, yeah.
Okay.
Okay.
Okay. Okay, I'm going to talk about chronic kidney disease. chronic kidney disease is one of the common diseases in elderly population. So kidney function as
Dr. Osama, can
yes.
you click on presentation mode so that the screen will be
I need it like this.
yes, thank you.
Okay. So the kidney function as measured by GFR or decline, so 10% decade after age of 40 in 70% of the population. So the GFR is reducing by like 10% after the fourth decade and more than 70% for elderly population. So the common causes of chronic kidney disease are glomerulosclerosis, which is the fibrosis of the kidney, and glomerulosclerosis, which is fibrosis of the kidney, and it is increased with age, and it is the leading cause of chronic kidney disease. Progression of medical illness, especially chronic hypertension, often lead to development of chronic kidney disease late in life. Clinical progression of chronic kidney disease in older adult frequently manifests as a decompensation pre-existing medical illness such as heart failure, I need to get rid of this one. Such as heart failure, diabetes mellitus, hypertension, or dementia. So the clinical progression of chronic kidney disease in older adult frequently manifests as a decompensation of pre-existing medical illness. And the common causes are heart failure, diabetes mellitus, hypertension, and dementia. So the chronic kidney disease have many causes, and the common one include glomerulopathy, especially due to diabetes, glomerular interstitial nephritis or tubular interstitial nephritis, which is medication related, and obstructive nephropathy and renovascular disease. Stages of chronic kidney disease. We have like 5 stages. Stage 1, kidney damage with normal function or an increase in GFR. Here the GFR is more than 90%. Stage 2, kidney damage with mild decrease in GFR, and here the GFR is 60 to 89%. Stage 3, moderate decrease in renal glomerular filtration rate by 30 to 59%. Stage 4 is a severe decline in GFR, and here the GFR is 15 to 25%, and offered or kidney failure less than 15%, and just need dialysis. So the name of chronic kidney disease actually is changed recently. Previously, it is called chronic renal insufficiency, and this by National Kidney Foundation, because chronic kidney disease include like the name is include every cause of chronic kidney disease. So it is not insufficiency. So it is like broad spectrum of kidney disease. That's why they changed the name from insufficiency to chronic kidney disease. Because if you have like stage 1, it couldn't be like insufficiency. It could be just like chronic kidney disease. Principle of management of chronic kidney disease. He emphasized preservation of residual function, renal function, using the same approach as in young population. So other treatment principles of chronic kidney disease, correct reversible causes, aggressive control of blood pressure, use of ACE inhibitor, ARB, and aldosterone antagonist, optimally control blood glucose, treat hyperlipidemia, minimize proteinuria, and aggressively manage phosphorus concentration. So decline in chronic in glomerular GFR or glomerular filtration rate are accompanied by broad range of complications. These include hypertension, anemia, malnutrition, metabolic disease, bone disease, and neuropathy, depression, impaired function status, and increased cardiovascular morbidity and mortality. So early recognition of kidney function allow screening for screening and management of these complications. Thus, we will prevent the comorbidity and reduce quality of life. So medication used in chronic kidney disease. So as you know that most of these medication are excreted by the kidney. So when you have impaired kidney, so most probably this will affect the pharmacodynamic and pharmacokinetic of the disease. So at GFR less than 50%, adjustment of the dose is recommended, and the dosing frequency may be needed. So you have to adjust the dose and you have to adjust the frequency of the medication. At GFR less than 30%, here you can talk about stage 3, stage 4, stage 5. So almost all dosage must be adjusted, especially analgesia, benzodiazepine, barbiturate, antispasmodic for both bowel and bladder, antihistamine, decongestant, muscle relaxant, and cardiac drugs. So all of these must be adjusted and should be used with cautious. Management of anemia in chronic kidney disease. First of all, you have to screen for anemia starting at stage 3 chronic kidney disease. Exclude other causes of anemia before treating. Iron replacement should be first step in treatment with the goal of raising transferrin saturation to above 20%. Medicare guidelines require hemoglobin less than 12.5 gram deciliter with hematocrit less than 39% to qualify for erythropoietin. So for anemia in chronic kidney disease, you have to exclude other causes such as vitamin B12, folate, thyrotropin, and iron should be checked first to know exactly what you are dealing with. And in case of iron deficiency, the most common cause, or approximately more than 50% of cases, are GI related. So you have to check if there is any occult blood or any other GI blood loss. So because of almost like 50% are GI related before to go further for erythropoietin or anemia of chronic kidney disease. Calcium, phosphorus, and bone disease in chronic kidney disease. All patients with GFR less than 60% should be regularly screened for calcium, phosphorus, and parathyroid hormone. So you have to maintain phosphorus concentration between 2.7 to 4.6 milligram per deciliter in patient with stage 3 or stage 4 chronic kidney disease. Start with dietary phosphorus restriction first. If parathyroid hormone is increased, so most likely you are dealing with secondary parathyroidism, hyperparathyroidism. So if the parathyroid hormone is increased, even the serum phosphorus is normal, you have to restrict the phosphorus from diet. Use phosphorus binder as soon as parathyroid hormone start to increase. If vitamin D is prescribed, carefully monitor calcium and phosphorus. Biphosphonate and are recommended for osteoporosis associated with renal impairment, except in patients with bone disease. So parathyroid hormone value help to distinguish between high turnover bone disease and dynamic bone disease. So you have to check the parathyroid first, then you have to deal with calcium and phosphorus to use the binder or to use vitamin D supplement. In older population, renal osteodystrophy is often complicated by osteoporosis. So that's why you need to do DEXA to know if there is osteoporosis or no. So sometimes there is overlapping between depression and chronic kidney disease. So management of managing depression in chronic kidney disease, you have to screen for depression. Is warranted for all patients with chronic kidney disease. Diagnosis can be difficult because vegetative symptoms can be similar to those of uremia or insufficient dialysis. Functional and cognitive decline are common, presenting symptoms of depression in elderly and adult with chronic kidney disease. So you have to distinguish between depression and chronic kidney disease because sometimes you have delirium or decline in the function, cognitive function of the patient. And at the same time, he had chronic kidney disease. So you have to differentiate between depression and chronic kidney disease because the symptoms are overlapping. Post-depression screening instruments have been validated in kidney failure population. Very low doses of SSRI are safe, but avoid long-acting medication. Nutrition and chronic kidney disease. Dietary requirements for patients with chronic kidney disease are complex. So intake of protein, phosphorus, potassium, all need to be controlled while managing adequate energy intake. So there is something called the renal diet. So the treatment of chronic kidney disease should include the nutrition department or dietitian to give them the appropriate amount of protein, phosphorus, and potassium in their diet. Once a patient reaches stage 4 chronic kidney disease, an experienced renal dietitian should be involved in patient nutritional management. End-stage kidney disease. End-stage kidney disease is that which requires dialysis or transplant for survival. more than 55% of patients with end-stage kidney disease are more than 60 years. Some of the increase in renal replacement therapy indicate greater willingness to offer treatment to older individuals, but much is related to increase in remaining life expectancy with attendance progression to chronic kidney disease. And we have to consider also, in addition to life expectancy, the condition of these people, because almost all of them are above 60 and 70, and even sometimes above 80. Here is the annual incidence of treated end-stage renal disease. As you see, most of the cases are above 60 to 64, almost more than 1,000 per million. And for 70 to 79, it is almost like 1,600 per million patient. End-stage renal disease dialysis. First of all, it should not be the first sole exclusion criteria. So you don't have to consider the age as exclusion criteria when you decide if the patient needs dialysis or not. Early referral to nephrologists ensure adequate time for discussing option and for creating adequate access. Creation of native arteriovenous fistula can require up to 6 months. Hemodialysis and continuous ambulatory peritoneal dialysis appear to be equally effective in older adults. So the choice between them can be individualized. Dialysis to patients with dementia is controversial. End-stage kidney disease, kidney transplantation. As in young patients, mortality rate in older patients with kidney transplant are considerably less than in those maintained on dialysis. Although older kidney recipients have higher risk of infection and sepsis than younger recipients, they demonstrate lower acute rejection rate and lower incidence of chronic rejection and greater survival probability than patients remaining on dialysis, even when corrected for level of comorbidity. Older patients and their families should explore the option of transplantation as soon as the need is there. End-stage kidney disease, hospice. In almost half of cases, failure to thrive is the driving reason for withdrawal from dialysis. And most people who withdraw from dialysis are more than 60 years old. And about 20% of dialysis cohort withdraw in any given years. So geriatrician has a unique role in educating nephrologists and patients about value of hospice. Here in summary, the moderately impaired kidney can maintain normal hemostasis, but is unable to respond to a challenge. Care is needed when giving older patient salt and or water. Perineal azotemia causing acute intrinsic renal damage is more common in older adults than in young ones. Serum creatinine is a poor marker of kidney function, as you know, because it depends on the muscular build of the patient and the excretion, and if there is any trauma or anything can increase creatinine. That's why it is not a good indicator of kidney function. So we have to consider the GFR. Chronic kidney disease is a disease of the older population and is classified into 5 stages based on the GFR. Preventing progression of chronic kidney disease is unimportant at any age. Referral to a nephrologist for a patient with advanced kidney disease is helpful for assessing with management and preparing for dialysis or kidney transplant. Here are some cases. We can go through these cases together. The family of an 85-year-old woman take her to an ER because of increasing erratic behavior. Normally, she functioned independently, but over the past few days, she has been forgetful, confused, and disoriented. History include pneumonia 6 months ago, hypertension and gastroesophageal reflux. Medication include hydrochlorothiazide, omeprazole, lisinopril, and multivitamins. Lab show sodium 128, potassium 3.2, urea 10, creatinine 0.8, urine sodium 80, and urine osmolarity 450. So which of the following is the most likely cause of this patient hyponatremia? Anyone can guess the answer? SIAD, water intoxication, hydrochlorothiazide, omeprazole, or volume depletion and poor oral intake. Anyone can suggest the answer? I check the patient taking medication, hydrochlorothiazide, omeprazole, lisinopril, and multivitamin, and sodium is 128, and his osmolarity is 450. So which of the following is the most likely cause of this patient hyponatremia? SIAD, water intoxication, hydrochlorothiazide, omeprazole, or volume depletion and poor oral intake. Anyone can guess the answer? So as you see here, the osmolarity is 450, which is normal, and sodium is low, as the patient taking thiazide. So most probably, as the most common cause of hyponatremia, first of all, you have to exclude any medication. So the answer will be hydrochlorothiazide. Case number 2, an 80-year-old woman is admitted to hospital with urosepsis. On examination, she weighed 60 kg and has a low-grade fever and increased respiratory rate. There is consolidation on the right lower lobe. Lab results show normal electrolyte concentration and serum creatinine concentration of 1.8. Which is her recent baseline value. She responded well to 2 days of IV antibiotic, and culture reveal E. coli sensitive to trimethoprim and sulfamethoxazole. And your pharmacist remind you that this medication require adjustment of the dose because of the renal. So based on the published equation, what is the patient estimated GFR? more than 90, 60 to 90, 30 to 60, 10 to 30, less than 10 ml per minute. Even if you don't know the equation, if you go to that slide for the classification of here, stage of chronic kidney disease, we said that severe decrease in GFR is 15 to 29, and these are the symptomatic patients, and these are the patients that need intervention, like renal replacement therapy or transplantation. So most probably it will be 4 or 5. It will be 15 to 29 or less than 15 offered or end stage renal disease. So here, most probably the answer will be 10 to 30 ml per minute. Even you don't know the answer or how to calculate using the creatinine and the age of the patient and to calculate the GFR. It is complicated equation, but you can guess the answer by the presentation. Case 3, 78-year-old man come to the office because of left knee pain for the past month. His history include long-standing hypertension, type 2 diabetes, ischemic cardiomyopathy, and chronic kidney disease. He is on hydrochlorothiazide, metoprolol, lisinopril, atorvastatin, aspirin, and glipizide. Blood pressure 132/80 and pulse 70. Left knee is tender on palpation and effusion is evident. After 12 days of celecoxib 200 milligram 2 times a day, patient retained because of dyspnea, increased swelling in both leg and fatigue. Blood pressure is 178/102. Urea 71 and serum creatinine 4.3. Baseline is 2.1. Urine analysis show urine sodium, low urine sodium, and no cellular element and no protein urea. So here, which of the following is the most likely mechanism by which celecoxib cause acute renal failure in this patient? Drug-induced allergic interstitial nephritis, acute papillary necrosis with renal obstruction, drug-induced acute tubular necrosis, hemodynamic renal insufficiency, nephrotic syndrome. Any guess? In other words, how non-steroidal affects the kidney and how non-steroidal cause acute renal failure. So the answer for celecoxib cause acute renal failure in this patient is due to hemodynamic renal insufficiency. So non-steroidal are common causes of acute kidney failure. Non-steroidal include cyclooxygenase 2, COX-2 inhibitor. This inhibit cyclooxygenase and renal prostaglandin synthesis. So renal prostaglandin act as a local vasodilator, as you know, and modify the vasoconstrictive effect of angiotensin 2 and catecholamine. Thus, non-steroidal can produce an acute decline in the GFR and renal plasma flow when given to patients with high angiotensin II and norepinephrine level. And this most often occur in circulating volume depletion due to, for example, heart failure or cirrhosis. In this condition, renal prostaglandin synthesis is upregulated to counteract the vasoconstriction action of angiotensin II and norepinephrine, and to allow adequate renal plasma flow to support glomerular filtration. And the patient in this case has heart failure and thus significantly increased propensity for hemodynamic mediated acute renal failure. Non-steroidal anti-inflammatory drug can lead to other renal abnormalities. This may include they may increase blood pressure and antagonize the blood pressure lowering effect of antihypertensive medication. So non-steroidal anti-inflammatory can also lead to sodium retention with resulting edema and exacerbation of heart failure, as in these cases. Finally, non-steroidal anti-inflammatory can lead to acute tubular interstitial nephritis, acute papillary necrosis, hyponatremia, hyperkalemia, acute ischemic renal insufficiency, and proteinuria. So cautious in this case of clinical history include you have to exclude, you have to not use any non-steroidal anti-inflammatory drug when you have renal insufficiency. I think that concludes our presentation, and if anyone had any question, please go forward to ask any question.
So much, Dr. Osama. Any question from anyone? So if there is no question, we can go to part 2 of the presentation of today. Dr. Osama?
Yes.
Can you stop sharing your screen? So we can start the next part, please. Thank you so much. Hello, everyone. I'm going to present like the part 2 of today, which is going to be like the 10 choosing wisely guideline for older adults. So in this guideline, like we want to avoid those kind of medication on older adults. So we're going to start with number 1. Number 1, do not recommend percutaneous feeding tube in patients with advanced dementia. Instead, we offer like oral assisted feeding. So the tube feeding does not prevent aspiration pneumonia, and the tube feeding does not improve survival, does not improve functional status, does not improve patient comfort. So number 1, like when it comes to feeding tube, percutaneous feeding tube, and oral assisted feeding, we go for oral assisted feeding. So number 2 for today, antipsychotic and dementia. So it's not the first choice to treat behavioral and psychological symptoms of dementia. Antipsychotic has a high risk of oversedation, falls, stroke, and cognitive worsening and death. That's why we try to avoid as much as we can using antipsychotics and dementia in older adults. So number 1, we say like the percutaneous feeding tubes, we use the oral assisted. And number 2, we try to avoid the antipsychotics in dementia in older adults. Number 3, metformin on older adults. So in older adults, I'm sorry, I don't know what's going on. Yes. So we're gonna avoid using medication other than metformin. So we're gonna use metformin in older adults to achieve hemoglobin A1C less than 7.5% in almost older adults. Some hemoglobin A1C targets in older adults between 7 to 7.5 and like health older adults, from 7.5 to 8% moderate comorbidity and less than 10-year life expectancy, from 8 to 9% multiple morbidities and shorter life expectancy. Metformin can decrease overall myocardial infarction and death. That's why we're using metformin on older adults. Number 4, benzodiazepine and other sedative versus insomnia and agitation. So we try to avoid using of the benzodiazepine and other sedative because their side effects which could be like cognitive, like memory loss, confusion, disorientation. It can be like a psychomotor side effects like dizziness, loss of balance, and falls, and residual morning sedation. Benzodiazepine reserved only for alcohol withdrawal symptoms and for refractory severe anxiety in older adults. Number 5, antimicrobials and bacteriuria. So do not use antimicrobial to treat bacteriuria in older adults unless specific symptoms are present. So the symptoms, it's including like acute dysuria, and one of those symptoms, change in urine character, change in mental status, or gross hematuria. And if there is like fever and leukocytosis, and 2 of those symptoms, which is like CVA tenderness, gross hematuria, and urine incontinence, urgency or frequency or change in urine character. We use the urine dipstick for leukostriae and nitrates, plus microscopic examination on those situations. But we're gonna try as much as possible, like we try to avoid antimicrobial and bacteriuria. Number 6, do not prescribe cholinesterase inhibitor for dementia without periodic assessment for perceived cognitive benefits and adverse effects. So adverse effect of cholinesterase inhibitor in older adults, including diarrhea, nausea and vomiting, bradycardia, and hypotension, and certain evidence for delay institutionalization, improved quality of life, and lessen caregiver burnout. Number 7, do not recommend screening for breast, colorectal, prostate, or lung cancer. Before we recommend screening for those things, we have to consider life expectancy and the risk of testing, overdiagnosis, and overtreatment. So in prostate cancer, they found from every 1,000 screen cases, there is 37 treated and 1 death avoided in 11 years. In lung cancer, from 1,000 screen patient, there is like 273 abnormal results, 36 invasive procedures, and 8 complications, and 4 deaths avoided. Breast and colorectal, from 1,000 screen, 1 death prevented in 10 years. Number 8, avoid using prescription appetite stimulants or high-calorie supplement for treatment of anorexia in older adults. So instead, optimize social supports, discontinue medication that may interfere with eating and feeding assistance, and clarify patient goals and expectations. For example, megestrol acetate and mirtazapine. Megestrol acetate has minimal improvement in appetite, but increase the risk of thromboembolism. So we don't want to put the older adults for high risk for thromboembolism, and it has a high risk for fluid retention and unfortunately high risk for death as well. Mirtazapine has little evidence to support use in absence of depression. So they found out if you give in mirtazapine for people they have no depression, it barely can stimulate their appetite on those kind of people. Number 9, do not prescribe medication without conducting a drug regime review. So giving medication to an older adult without drug regime review can increase the risk of drug effect, drug interaction, medication non-adherence, decreased functional status, and geriatric symptoms. In 2005, 4.3 million healthcare visits were attributed to adverse drug events because people prescribing medication without conducting a drug regime review. 35% of outpatient and 40% of hospitalized elderly experience has an adverse drug event. So before describing like a medication for all the others, we have to conduct a whole drug regime review. And the last one, do not use physical restraint to manage behavioral symptoms of hospitalized older adults. So physical restraint can worsen agitation, delirium, and can also lead to serious injury and death. Effective alternative can be frequent family contact, avoid short-term memory questions to limit patient agitation, discontinue, hide unnecessary intravenous or monitoring device, environmental modification, and identify and managing condition causing patient discomfort. In summary, so those are the 10 guidelines for older adults. So number one, we said again, do not recommend percutaneous feeding tube in advanced dementia, but we're gonna use oral assisted feeding. Do not use antipsychotic as the first choice to treat behavioral and psychological symptoms of dementia. Avoid using medication other than metformin in most older adults. Do not use benzodiazepine or other sedative in older adult as first choice. Do not use antimicrobial to treat bacteriuria in older adults unless specific symptoms are present. Number 6, don't prescribe cholinesterase inhibitor for dementia without periodic assessment. Number 7, do not recommend screening for breast, lung, prostate, and colon without considering life expectancy and the risk of testing, overdiagnosis, and overtreatment. Number 8, avoid using appetite stimulant of high-calorie supplements for anorexia and cachexia in older adults. Number 9, do not prescribe medication without conducting drug regime review. And number 10, do not use physical restraint to manage behavioral symptoms of hospitalized older adult with delirium. And that's conclude part 2 for today. Any questions?
Thank you so much, Dr. Mazin and Dr. Osama. These are great presentation, concise and to the point. Thank you so much for your great work, and we really appreciate your effort, and thank you. Any questions, guys? So it's important to know the basics of when you see older patients with chronic kidney disease, especially when you are prescribing medication. One of the important thing you consider is the GFR, or the creatinine clearance. So certain medications, they need to be adjusted, the dose for older patients. So keep that in mind. Some antibiotics, for instance, you want to reduce the dose. For example, Neurontin, you want to divide the dose. Instead of 3 times, you give the patient 2 times a day. So just remember that. The second point I want to share is when you are dealing with older patients, remember we are sometimes the cause of the problem. What I mean is the medications. So any patient come to you older than, let's say, 65 with any problems, look at the medication and try to blame one of the medication as a cause. If the patient had falls, blame antidepressant or anti-blood pressure medication or heart medication, something along these lines. The important point that I want to share with you. Thank you so much.
So if there is no question, we can go to part 3.
Actually, I have a question for all the group. I have here 22 participant. So let me share with you this poll. Can you see it?
Yes, we can see it.
Okay, so 2 of you answered. I'm waiting for the rest, 3 of you. Okay. So 1 more minute and then we can discuss it. So 16, 4 more of you or 6 more. Okay, so it's divided 3 to 1 or 75% of you guys said 75% said yes and 25% said no. And I want to share with you. Okay, how do I do that? Can you see my screen or no?
Not yet.
So there is an article in New England Journal of Medicine. It's a prospective piece or article, came out just in the last issue. Or I'm using my phone, so it's kind of challenging to see. Okay, let's see if I can share screen. I couldn't share the screen with you, but basically it's an article, first impressions. Should we include race or ethnicity at the beginning of the clinical case presentation? And this is written by 2 physicians. One of them is primary care physician, and the second is a writer. Also, he's a physician, but he writes a lot to New England Journal of Medicine. Both of them looked at previous studies done in this area, and they found out there is no benefit of using the race, especially when you are starting your case presentation, like this is a 75-year-old African American or Black American male with this and this. So most of the time, this will not help the case or the listener or the audience. If you mention the patient is Black or white or Caucasian, it's only in a few cases like sickle cell anemia or like some other specific conditions, which is not usually common thing. So maybe you can read the article and it will help you just broaden the idea, the picture. Some of the medical schools nowadays here in the US, they don't push for this kind of presentation. And during residency also, you may find some of the attending will ask you not to mention them because race will not play a major role in certain conditions or common conditions. But something to think about. Thank you. We can go to the next part.
The next part is going to be like the project updates, if there is any updates on the projects. Any updates, anyone?
Yeah, this is Lubaba. Good afternoon, everyone, and good evening. This is regarding I think, the role of activity abstract submitted for AMDA. Hadi reached out. She's not available to attend today. Unfortunately, she's a little bit sick. But she reached out to AMDA and asked for a virtual presentation. They gave her the opportunity to do a virtual presentation in their meeting, but she's waiting for the criteria to submit that virtual abstract or poster. This is regarding the role of activity. The current project that we will be working on, the long COVID, hopefully we'll meet next week. I reached out to the team late this afternoon or this morning, but we will hopefully we'll meet next week and we'll decide which direction we will be going. Those are the couple projects that I know about. Thank you.
Thank you so much, Lubaba. This is great.
Mm-hmm.
Excellent. Thanks for sharing.
Mm-hmm.
Anyone else wants to share? We have a couple of abstracts were accepted. Anyone wants to add more information from the two teams submitted these abstracts? Go ahead, Selma.
Hello, everyone. I had an email from the committee. They wanted me to include long-term care implications and mention long-term care into my abstract. They said if I can include these things, then I can present it next year.
Excellent. That's good. So maybe we can work on that. Excellent.
Yeah. Thank you.
Thanks for sharing, Selma. Anyone else? So I think we are going in the right direction and we are gaining some ground here. This is good news. So the other two posters regarding cardiology and using echo, both of the abstracts were submitted and accepted. So this is also great news. The leaders for the projects will reach out to you for the team to get the task and to divide the job between you and for presentation, poster preparation, and how to gonna present or go ahead for the next step. Excellent. This is great. Great news. Anyone else wants to share? Again, I want to make sure team leaders reach out to the team members and make sure everyone is involved in at least one project. And I know maybe some of you might be busy or might not be able to attend the meetings, but if you can just spread the message between you guys so that everyone has at least opportunity to participate in learning the steps to complete a project, and hopefully will benefit every one of you in the near future when you start your residency. Excellent. And speaking about the leaders, I don't know who is the leader for the orange team. If someone can let me know from the team or from anyone, just send me an email when you get a chance. And speaking about residency and interviews, any update anyone wants to share anything, or we can go to the next agenda. Mazin, you can lead.
Okay, so the last part of this day is going to be like the mock interview is going to be presented by Dr. Selma and Dr. Hiba.
Great.
Dr. Selma?
Yeah, I'm ready. Hiba, are you ready?
Take your time whenever you're ready, get started.
Okay, thank you.
Yes,
All right.
I'm ready. Selma.
Hello, Dr. Hiba. Thank you for joining us today on our interview panel. Why don't we start with giving us a brief introduction about yourself?
Thank you, Dr. Ali, for this opportunity, first of all. And yes, I will say my name is Hiba Walama. Originally from Sudan. This is where I was born and raised, and have my medicine degree in there and finished my internship year. After I finished my internship year in Sudan, I moved to Saudi Arabia and I practiced over there as a general practitioner. My experience was really great, and I introduced to advanced medicine technology and treatment. In 2016, I moved to the United States, here where I started to live my dream to become a psychiatrist in the United States. So to do so, I finished my step 1 and 2 and 3. And then I had a certificate of public health science at University of Colorado. And now I upgraded to MPH epidemiology in my final year. So, and also I'm a research fellow at Michigan State University. And in this experience, I'm learning how to conduct research. And at the same time, I'm working on Harm Reduction Center, which is a safe syringe exchange program. So on a personal level, I love cycling and cooking. So this is all about me.
That's wonderful. Thank you. Seems like you have your hands full with a couple of things. Let's jump straight into, more, like deeper questions. Tell me about a situation, a difficult situation that you've had to handle, and you managed it successfully.
All right. So I remember I was in charge in one of my rotation about the scheduling. So there's one of my colleague, he was absent like twice from the night shift. And my other colleague who's in the team, they came and reached out to me and they said they completed the night shift and he doesn't appear on time. So I just reached out to him and I asked like, what's going on in your life? What's happening? And with a little bit of conversation, I know that he has a family emergency and he need to stay with his parent at home, specifically at night, because he doesn't have anyone to stay at night with them. So we managed as a team the schedule, and we told him he doesn't need to do the night shift until he finds someone to take care of his parents. And whenever he has any situation, he just needs to tell us and we will be there for him. So I think that's the situation I faced.
Excellent, excellent. So tell me a little bit more, Dr. Alama, why are you joining this specialty?
Psychiatry. All right. So I see myself as a psychiatrist for a couple of reasons. And I start with the one, first of all, I love the field because this field particularly focus on the patient feelings and its relation to the brain complexity and how to return a patient back to functionality. So having these three components, which is the functionality and the complexity and its relation to our emotions, make me fall in love with the psychiatry and how by understanding someone circumstances and having a brief history from childhood to adulthood can change someone's life. So the second part is this field just not is not just only it's focused on treatment on your feelings, but at the same time it's focused on physicality. So I call it the spirit of medicine because it has connection between both the brain and the functionality and the physicality. So that's why I love psychiatry, and I see myself someone who can spend his whole life to understand more about this complexity of science.
I couldn't agree more, and that's a wonderful way of explaining it. So what are your career plans for the next, both short term and long term within this field?
Yes, so I see myself who's for now, my short-term plans is to do the residency and expose myself for the subspecialty of psychiatry. And I see also I'm leaning toward the substance abuse, and that's through my career. I see that's how substance abuse can affect our population. So I want to enroll in this, understand more about this field, and I want to contribute in this particular subject, the substance abuse. So I started now doing a community work with a harm reduction. And through my work, I understand more about these population particularly and what's their barriers before just jumping to the treatment of the substance abuse. So I'm seeing myself leaning toward this, but I would like to expose myself to the other subspecialty of psychiatry.
Wonderful. One last question from my side. We've interviewed excellent candidates. What are you hoping to bring to our program? Why should we pick you?
I think you should pick me, and I know all the other candidates, they are competitive and they have also a strong criteria that you're looking for. But I think I'm a very responsible person, and that's proven through my whole career. I'm always available for my team, and whenever there is a help needed, I'm in the front line. I don't hesitate ever to bring help and to participate and contribute to the work. And I see that's my responsibility as a physician and as a team player. Second, I'm a very adaptable person. I was able to work in three different settings with three different community background, and I was able to adapt and infuse in these communities and understand about the pathophysiology of this population. So I bring these two and definitely grow more in your program.
That's truly insightful. Thank you so much, Dr. Alama. I wish you all the best, and thank you for interviewing with us today.
Thank you, and thank you for giving me this opportunity, and I'm grateful for this.
Thank you. All right. I think you did a really good job. You did not pause. So you spoke, the flow is really good. Personally, I liked when you commended that there were other excellent candidates. You didn't deter from, from experience, and then you went on to describe your attributes. So I think you did great.
Okay, that's good. And how about psychiatry? Did I convince you? Why psychiatry, or it's need improvement?
I think you were able to tie in both. You mentioned both. Having to be like show the emotional aspect, but also the medical aspect of it, and then you managed to tie them both nicely. I don't know if anyone else has input.
Right. And tell me about yourself. Is it like short and you didn't lose your concentration with me?
I think it was great. It was compact. It got to the point. It gave like a summary, a good summary of who you are.
Okay, thank you. So, okay, thank you, Selma. Yeah. If anyone please have any comment, please.
I think Azza and Sumi raised their hands.
Hello, everyone. Thank you, Lubaba. And great job, Hiba. Just allow me to compare between your first mock interview and this one. That is a big improvement. Excellent. And your answers was close to perfect. You seem like to perfect tell me about yourself. I like your answer. It's more engaging. But I have I noticed one thing. I don't know if you mean to do it or that is something just for today. You are kind of soft and low, and I like your personality way better in the first mock interview. I don't know if you mean to do that or not, but you were you look more motivated, more passionate. Your answers were like coming from your heart. Mm-hmm. Maybe because you rehearsed this so many times, and you're not like as nervous as you were in the first time. Maybe it's just one thing today, or just disregard this if you feel that this is not true.
So I couldn't understand. So this time I'm a little bit low, not like before.
Yes, and I like the way you answered the first time. Your personality was showing. I like your enthusiasm the first time. And maybe here the low voice thing, and they will perceive that as some lack of interest, maybe.
Mm-hmm. Actually, I mean it today because I'm a very in general I'm in my life I'm very excited person. So I'm trying to tide myself, because sometimes when you're too excited, you can just
you're trying to
I'm trying to be reasonable.
I know, but I don't know, maybe that's just me. But I like the way that you're answering the first time. You look more enthusiastic, you look more motivated and passionate.
Okay,
Your
so I need just to adjust my motivation
level. Your answers are 100% better. If you apply the same answer to the first one personality.
First personality, believe me, it doesn't work all the time.
Okay, all right. Okay, thank you so much.
I would adjust it. I just do try to combat, to control my feelings. That's what I'm trying to do.
Okay.
But I think I make it too tight this time. So thank you for this.
All right. Okay. You're welcome. Thank you so much, Hiba.
Yeah,
And good.
Thank you, Rosa. Sumi?
Yeah, thank you, Eva. It was great. I just want to add something else also, as we all know you for a long time. So I have the same concern like, Aja. So because I know that you are very, straightforward and very energetic person and enthusiastic person. So I don't know because of that, as I know about you, I feel like you're a little bit low and calm and quiet, and your personality. So I think it is also, we all have to balance, like, you have to be yourself also. Other than, your enthusiastic nature or your, like, the truth behind you will not reflect to that program. I mean, we always try to balance, same with me also, because I feel like I'm also become very excited or something. I try to, balance. But other problem, I'm telling you, because I don't know, like, like for me, like, there are a couple programs, maybe where you will be interviewing, somehow they may know from either you did externship or observership, something like that. So, the people might have an idea about your personality, right? So during the interview, if you are so calm and quiet, so they might think that, it's not real, right? So I just want to warn you that. So, as much, because this is a platform to improve and we are not grading anyone. So, whatever we have our perspective. So that is, I mean, be yourself also. I think it's a, real thing. I know, like, your personality. So that is one thing. Another thing, like, I want to mention from tell me about yourself. As you wanted to be a psychiatrist, so when you like describe that, just put at least one sentence or two sentence, like what from there itself, or from your medical school background, or from beginning of your life, that, oh, like, I was growing up seeing some mental disorders, around the community or among some population, like, and that makes me to go to medical school and choose psychiatry, something like that. So you can, from the beginning, like, that was your goal and you are fulfilling your goal. Or even, like, you mentioned that you have a public health, like a graduate certificate, I guess, and probably that you transfer to a master's. So, if you have worked any kind of psychiatric research, even this fellowship, if you work with the patient, like with because throughout your interview, like, I was not able to connect, like, what experience did you have for psychiatry and why you are so interested in psychiatry now, or what motivates you for psychiatry. I mean, like, there should be some connection throughout the conversation. I hope that I was able to make you understand.
No, that's a good comment. So I need to just emphasize at least one point. Why psychiatry in my tell me about
Yeah, because those program directors are psychiatry people. I think, like, it's for every specialty. They want to know why you want to come psychiatry, and why, and you have to prove yourself from the beginning that you have that desire. We should not, I think, reflect that, oh, I'm here in this country, so basically I wanted to be a cardiologist, but as we are IMGs, we do not have any choice, so I'll take whatever I get. Like, to avoid that situation, you should prove yourself that from the beginning you are so motivated to do psychiatry or something like that. You have to connect. So I feel like, as a
it's a
interviewer
thing.
or something, yeah, I was not able to convince 100% that you are, from the beginning of your medical career or your research career, you are truly interested about psychiatry.
All right.
One thing also, I had to interview last week. That was my interview week, actually. So as I'm here, I just want to finish that up also. from the experience, it was like the questions were almost, like it's not very, I would say like not very difficult questions, but I think the virtual interview, it's like, it's very difficult. That's my understanding, because you have to basically concentrate, especially that 3 hours or whatever, 4 hours, every single second, basically. Like during, I feel like the in-person interview it's okay, it's more relaxing kind of, because you are communicating that person in person. When it is virtual, like there are so many other things in your mind. So I mean, preparing with a person or a family member like 2-3 hours is also a one kind of thing. I feel that was a little bit challenging for me, like concentrating, because my interview was scheduled actually one after another, like like program director talk, followed by a resident panel, followed by PD, followed by assistant PD, like that. So it was 3 continuous hours, so I had that thing. So like you don't know how, because they rescheduled it like in the last minute.
Okay.
The thing, I don't know that it is because of my because in my CV, as I'm working with the vaccine hesitancy program, there are a lot of questions asked regarding vaccines. Like it's a very common questions, but I feel like as a physician, because I do not have any idea that questions are asked for the other candidate as well. But there are some questions like you should be prepared for. So I would suggest each of you, every candidate here who is going for interview, please review the materials from CDC. I can even like send in WhatsApp you all, like after this meeting, that just the recent data, and let's say like how many percentage of people in US are fully vaccinated, partially vaccinated, how far are we from developing herd immunity. Also, if some of you have a public health background, of course, everybody has a medical background here. I think we should know those things. And, like what is the perspective, what is your perspective about Omicron virus? And, like, is it like how vaccine is effective for Omicron virus as of today? Like those kind of things. And what do you think about the vaccine development for the young child, such as 6 months to 5 years? Like we all should know about at least some basic information about the vaccines. Otherwise, it's all the questions and everything was like, we already know. And of course, like no matter how much you prepare yourself, you will be nervous.
True.
Thank you.
Thank you for your comment. I do really appreciate that.
Lubaba, go ahead, please.
Yeah, so first of all, you did amazing. You were great. I like your answers. They were very consolidated, your language choice and the wording, everything. But I will add my vote regarding the personality, maybe because we know you. I like, frankly, I'll say it. It's not like for you to improve. I felt like you're acting or pretending. So I did not get that Hiba that I know. And as you said, like I felt like you were a little bit guarded today. You were answering good answers, but not with kind of passion or Hiba that we know. So I think you need to just adjust the balance a little bit, to that area. But regarding tell me about yourself, it was nice and concise. It's compared to the first one, it was really a great improvement. I just want that tie at the end, instead of saying like, this is about me, you can say, and I'm here and I'm looking forward for completing my journey or something, just tie to the program. Always remember to tie everything at every question to the program. Just a reminder, I'm here for residency. And yeah, and regarding the situation, she asked you about the situation. You did that very well about the schedule and how did you solve the problem, but you need to like mention maybe what did you learn from this kind of interaction. Show them that you are a very good communicator, you reach out to people, try to ingest kind of something of word like this to make them feel that you are a team player or stuff like that. Whenever you get the chance, mention attribute about yourself. And I second what actually Suomi said, add something regarding psychiatry and tell me about yourself, add something if you can. I think you did that regarding you finally like following your dream or something when you came to US. You came to US because it's, and mention maybe if you had, I think they always recommend it need to be concise, but try to mention the big things about that you were doing or you did and tell me about yourself, because you might not get the chance. They may not ask you, they may not ask you the question, why psychiatry? Just tell them from the beginning, like you are passionate about psychiatry, because, for example, as he mentioned, one sentence or two regarding that. Yeah, and the public health master, you didn't mention it and tell me about yourself, right?
I mentioned it. I said I did certificate of public health, and now I graded to MPH epidemiology, and then I moved to the research fellow, and I said at Michigan State University, and now I'm learning about how to conduct research.
Okay.
I move on, but I need just to, I try just to tell me about yourself as a bait and telling small thing. And then, because most of the time I notice something, interviewer, they don't read your CV.
Exactly.
And you just, when you tell them big things, you track them what to ask you.
Exactly.
Exactly.
So yeah,
so when you
maybe
say big things, that may grab their attention to something.
Exactly, and try to change your tone. Like, so maybe I was really focusing. I was like, "Where is Hiba? Where is Hiba?" Maybe I didn't hear that, but like try, for example, whenever you are starting talking about something, you change the tone, so you will grab their attention. And actually, I'm doing this and this now. Like, yeah, just like change your tone, that they will they will be more attentive. But other than that, you did great. Tell me about why psychiatry. It was really nice and very good answer, but I still feel like whenever you add something personal to why you are hooked to that, it will be more meaningful, because that will show more of your authenticity, if we can say that. Because this answer might be said by anyone. I can just like memorize this and come and say it, right? But you need to add that passion to it. And maybe if you find anything personal story, that will be really helpful. But you did great.
Thank you. And guys, I just find out that when I'm too excited and too happy, I divert my my answer. I'm not focusing in the answer, and I got excited so much, and sometimes I miss answering the main questions because I'm so excited. I want to tell and I want to speak. So
I believe you. You know what? This morning I remember like there is something I really prepared to say it in the interview, and I didn't do it. I didn't remember to say it. So
yeah, that's what happened to me last time. I was so excited, and I want to tell them everything about me, and the time is really short. So I'm just trying to adjust this timing thing with my excitement.
You will do great.
Be more formal.
Okay, good luck.
Thank you, guys. Thank you. I appreciate this feedback. Selma?
I just had one comment, really. So I think the main difference from last week's mocks and today's mocks was that you came across very professional. You never know what the interview panel is going to be like. And so, if that excitement shines through and they accept it, then all good and well. But if not, and you have a really stern interviewer or someone who doesn't, laugh or appreciate, like, that bubbly, fun personality, it might backfire on you. So it's always good to be professional and confident, and answers have to be genuine, because they can tell a genuine from a cliche answer. So I think if you like combine all of these features, having a genuine answer, but also being professional, then you can steer the interview to your benefit, to your advantage.
Okay.
Yeah. And, you know, it's like you mentioned, your excitement can get a little bit out of hand, and then it completely throws off the rest of the interview. So that's my only input. I definitely like today.
I need just to adjust me and to have this sense of, fun part when there is, in certain part, I don't know what to figure, not all the interview being happy and excited about everything. So yeah, I would just try to mix, professionalism with my personality. Okay, thank you.
And Hiba, one more thing, it's not like only you. I think it's a human nature, when we become overexcited, when we are, in a situation like this. But this interview is something that you'll be nervous. And as I told, no matter what, like how many times you prepare yourself, you'll be nervous. But at the same time, I think we have to regulate our personality and we have to show them that we are best for their we are best candidate for their fit at the same time, because they have to decide based on our personality also, because imagine we are basically working at least 3 years with them and also beyond. As Dr. Nadir mentioned, probably that program may hire you after residency as well, but at a minimum 3 years. It's a long period of time. So, personality is I feel like it is not about only score. I used to think only about a score, but I think that is the reason. That's why the step one, all of probably from January, it is the pass and fail exam. So, because so many programs, they found out it is not about only a score. The personality matters a lot. So, they just want to take off the scores, and it is pass and fail. And as a human being, I think how you are and who you are, that matters most than how much did you do well in your exam at the end of the day, being a physician. So that is one thing. Also, I want to ask you one question. As a physician, what is your philosophy?
As a physician, my philosophy and my goal, I would say, is always to be there for my patients and provide the best of me in terms of care, and being always a good listener for my patients and show compassion. And it's not just only about treatment; it's about being human and and show empathy. And try, of course, to give the high quality of treatment for my patients.
All right. I like your answer.
Really? Actually, you come to me with the question and I was like, what?
No, I was, I wanted to ask that question, and then, finally, so I thought I'll take that opportunity. But yeah, you may be you may definitely have to face some questions you are not prepared for.
Yeah, that's true.
So it's, you don't know where it is coming from or whatnot. And also I would suggest that don't think that they will not review your CV or personal statement. Some of the faculties or program director, they're very thorough about your CV and personal statement. Because
and some not. Actually, my experience is, even I was tell me about yourself, and when I'm speaking, I felt like she's surprised about what I'm saying. Like, oh my goodness.
No, it depends on that person specifically. I think some people want to have a background, want to know about your background before interviewing you. And some people does not do that background check before interviewing you. So it depends on how that person wants, to be
before and some after, yeah.
Yeah, so it depends, how. So we have to be, as a candidate, we have to be prepared for both. Because one of the faculty was telling me, as one of the comment, what is your strength or something when they asked, then I was about to explain that, you know, the last 3 years I'm working in a university as a, you know, research manager, and I had I had to face, you know, a lot of struggles, and then I had to make sure that, you know, all of my teammates, including medical students and resident physician, you know, I have to consider their needs, their time, I have to value their time, and all things considering, like, you know, I was able to successfully run so many research projects, and about, you know, I was able to meet the deadlines of the project. And you know, all of a sudden he mentioned that, yeah, I know that your current supervisor, you know, like in his personal statement, he mentioned that. I was like, oh my God, like, you know, your current supervisor in his LOR, he mentioned that. So I was surprised. That means like he read personal statement, you know. I did not comment anything because that, you know, LOR was waived, right? So no, I should not comment anything. I said, oh, okay. But, you know, I was very surprised that they, you know, he knows inside out about my LOR or something. So, you know, that's what I'm saying. You have to be prepared for both.
Yeah, true.
Thank you.
Thank you. Thank you, Sumi, for this, you know, comprehensive feedback. I do really appreciate that. Selma? All right. I think this is, Selma, do you raise your hand or? Okay. So, anyone has a comment? Dr. Nadir?
So all in all, I think you did great. And as the other fellows mentioned to you, I appreciate their input, their feedback. So I agree with making some adjustment as far as how you come across, especially when they ask you about your interest in the area or the specialty. You have to show them you are enthusiastic, you are having this energy. You come across like I'm the girl for this position. No one else is better than me. So you have to show that when they ask you something that you love, and use your body language, your hand gestures. But I think your answers were perfect. I agree with what Lubaba mentioned at the end of each answer. If you can come back and tie to the program, and try, if you know things about the program, mention them, inject them in the middle of your, or at the end. I know your program offers this, or they have this, or this, the community in your area, this is something that show that you did some homework about their program. So because everyone else will give the specific answer to the question, but you will be unique when you tie your answer to their program and add something that indicate you reviewed their area, their specialty, or their things that matters for the resident, for the community, for the patient population, something like that. But I think you did great. I think you're great.
Sorry.
No worries. If you wanna answer that, that's
pardon me, Doctor. There's interruption came in the middle of the conversation. Well,
so if you can tie at the end of the answer to the program, and if you can mention something about the program within a couple of the answers, like answer number one, you can state that you are interested in their program because of this. This is at the end of
In
your
the beginning or so thank you for this opportunity, and I do really appreciate that. I'm really interested in your program. I can initiate that and tell me about yourself because of one or two reasons. Don't expand and then go and tell about myself. Okay.
yes.
Okay.
Or in
I can give like
second
hint
part, you can-
one thing. So thank you for interviewing me in this program. I really like that your program have a variety of subspecialty of psychiatry that will expose me to different perspective of a psychiatry field, the psychiatry fields, and then move. So my name is love. And okay.
And the same, you can use a similar idea at the end of next
Conclusion.
question, next answer to second question or third question. You want to add something, blah, 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 about the program after you give the answer. So let's say they ask you what's the weaknesses or what strengths. So you say, my strength is I love to be a team worker, whatever, team player, and I work with the different teams in Saudi Arabia here in the fellowship. We completed different projects, and I know in your area, your residents, they work in a team, whatever, something tied to their program.
Yeah. Actually, yeah, I in the subspecialty, I can say because we're only 5, they only accept 5 in the program, so that's a focused training for me, and especially the faculty, they 100 faculty with subspecialty, and being able to train under these people and focus education, that would be a great opportunity for me, definitely.
So just mention something like that. This
Yeah.
point, inject it somewhere in your answers.
Yeah.
And as Lubaba mentioned, in each answer, try to polish yourself, add something unique, each portray yourself with some words about and this is because I'm whatever hard worker or
Yeah, I do agree. Okay, so every time we learn something, I'm just trying to adjust my excitement because of that.
Yes, you are doing great. You are doing great. So
yeah,
if you are ready, if you want to add a little bit here, there, will be additions. So whatever they told you, the fellows, as feedback, take it and adjust. If you don't take anything out of what we said, you are ready. So don't worry.
No, believe me, when I'm got too excited, I don't let the interviewer to ask me. I will keep saying and telling stories and moving from stories. So sometimes you need to
when you tell, don't go out, go into their program or about yourself as far as things that they can remember you instead of others.
Okay.
So whatever trait or whatever character, whatever thing that represent you, you think you are this, mention them in your answers somehow. Add one of these in answer number 1, answer number 2, answer number 3, something like that.
Okay, definitely. Thank you, Dr. Nadir, for this feedback. Appreciate it.
Sure. Anyone else? You'll do great. And so keep it up and good luck.
Yeah, inshallah. And for the psychiatry answer, is it like convincing? Baba, she mentioned something really important is to tie it to story and then say why, like, is psychiatry.
Yeah, I agree. If you mention some stories or some background about why your answer is perfect, but if you want to make it a little bit higher level, mention something personal so that you're really interested in this and you really see yourself in the future, whatever, something like for you personally. Is it for your community? Is it because of whatever thing in your mind, you can just share.
Okay. Yes.
You're doing great. Excellent.
Thank you.
Good luck.
Thank you, Sulafa.
Thank you, both Hiba and Selma, and thank you, Dr. Mazin, Dr. Osama. So we can move on to next agenda if we have anything else. Perhaps someone or maybe some of you who did interviews in the past, if you want to share some of the tips or some of the things that you faced during the interview that may benefit the rest. I know Sumi, Lubaba, maybe someone else had some interviews. If you have a minute or two.
Yeah, thank you, Dr. Nadir. I think it's it's most challenging for the virtual interview I faced is like concentration and like eye contact. It's very challenging for continuous 3 hours or whatever, and be prepared for some unknown questions. And and as everybody mentioned, I think it's 3 things you always have to master. One is your CV, your own CV, your personal statement. Also, I think it is better to review your LOR, like what other people or your mentor talk about you, so you can connect those things to your answers. And also the program. It is very, very important to know the program inside out, like such as like, this program is a first of all like a community-based program or university-based program. So what are the qualities for, university-based program? What are the qualities for community-based program? What are going to they offer? Like, university-based program has a high academic profile. So to maintain that, each of the residents, they have literally they are involved in multiple research project, and then case presentation and so on. Some of the community programs, although they are not university program, but still they are even like more, the residents is still like published a lot, and research project involved in so many research project and whatnot. So if you are doing a master's or currently or something in a research work at US, you should be prepared for that type of questions, and how you can connect to your experiences with their program, like your past experiences, such as Hiba has literally 3 continent, like 3 continent experience, I would say, like Africa, Saudi Arabia, and US. So how all this experience can bring together to their program, and how do they benefit. Certainly we might think that this is a common scenario for IMGs, but it's not. They evaluate, because you basically prove yourself that you have the capability to work with multiple diverse group of population, multiple demographics, something like that. So always connect to that programs. And some programs, they are situated in the urban area, some are rural area. So what kind of most common diseases you are going to see when you are a resident, or they as a program, or do they serve, like do they serve the underserved population, or like city population, or like demographics, like multiple diverse group of population. And if you have that experience, you can connect that okay, I have this experience and I think I'm a good fit for your program, because your program also serve a diverse group of population, something like that. Or if you have a background of serving underserved population, and the program also do the underserved, you can connect that, something like that. Or like if you did a research project or something, that also, like you can read through the faculty's projects or something. Oh, I found out that I did the same kind of project before, which one of the faculty I noticed that they did also, something like, you always try to connect yourself, your work with the program that benefit, and be yourself, be confident. I think everybody here is, very, very, I would say, like, I mean, all of us here is, I felt like eligible to do residency. I mean, more than qualified, but we just have to sell ourselves, you know, although I don't want to use that word, but that's the real truth. You know, we just have to sell ourselves very confidently. That's all, I guess. If anybody has any specific question for me, I can answer. Otherwise, you know, I cannot share exactly questions like what they have asked. That's, you know, that's the violation of the program. But if you have like any other questions, how did I answer those type of question or that kind of thing, I may answer. Thank you.
I have a question for you. Actually, it's I see it myself kind of, you know, indirect. So they say they ask it to this type of question. So if I'm ask you to tell me something about you that can make me memorize you among other candidates.
All right, so I would probably throw my, you know, everybody's experience is different, right? So what I would suggest, like your most recent experience or most recent works, or like your program, something like unique you have done most recently, and that is like would be beneficial for the program at this point, at this time, you should mention that. For me, like, you know, I am doing a vaccine hesitancy program, basically, I know, like overcoming vaccine hesitancy among underserved population. So I connect that I feel that is, you know, it is the right time in a right way. And this you know, this project is going to benefit for the community, for the underserved population as a whole in a global perspective. And this is unique for my master's program, also for the population I'm going to, I'm dreaming to search, you know, serve. So, I mean, you know, that's how I connect. So, I mean, the most important thing is it's unique for each of us, but I think the most recent work and most recent, like, you know, like, especially if you have anything related to vaccines, anything related to your COVID work, or even research work, even if you published an abstract or like present an abstract regarding COVID, which like, you know, like related, especially for you, probably psychiatry related things, and how like that abstract or that research data, what do you think, how is it beneficial to your patient population you are going to serve, like psychiatric group of population, you know, that is a good answer, I guess. I think you're mute. Yeah.
So you're right. This approach, as from other colleagues that I do hear from them too, it could be approached in two ways. So the first is a professional way, which is your strengths, and actually that's what you're doing in your CV. Something you see that is unique, or something could be hobby, something fun about you as a person. It could be like if you have mastering some of sport, for example, and you have a reward in your home country and you were professional in that, so you can mention it in other perspective also that can reflect who you are in a personal level. So someone who like to compete, who like he has a physical stamina, which is of course may reflect your also your mental stamina too, because we know it both can link and both can train each other. So yeah.
Yeah, also I think the question can be defined format, like, you know, it can be something like, tell me about some fun facts about you. So, you know, like you have to basically finish this answer within 2 minutes, because not even 2 minutes, basically like 30 seconds, because 2 fun facts about you. So, you know, it's like, say like I mentioned that, you know, like I am learning Spanish with my daughter, using a app called Duolingo. So, you know, that's fun fact about me, because at the same time, they have the patient population. They also serve Spanish speaking people. So, you know, as Lubaba mentioned, Dr. Nadir mentioned that you have to connect every moment to their program. So I want to let them know that besides my, you know, like other languages, I am also trying to learn. But that is fun fact about me, because I also told them that like it is convenient as I'm learning with my daughter, because I'm learning with my daughter as well, from my daughter as well. So when it comes to learning, I'm open to learn from anybody else. It could be from my junior, like a co-worker or faculty. It can be from my senior faculty. So as I'm learning every day from my daughter. So, you're showing that your openness to learn, at the same time, you're learning something that is, beneficial for their program. And that is also fun, right? Like, you're learning something.
Having your daughter.
Yeah. So, like those answers I prepared, but, like, of course, like I was prepared for those questions. But, as you have to connect. So if you know that the program, like serve the Spanish speaking people or like Chinese speaking people. So made your story like that, but be careful, because some of them might know Spanish. Just, hey, teach me something about Spanish. So, just, but that's true. Like I'm trying to learn. I don't know. I probably know 10% of Spanish, but I can, I can teach them. But I mean, that's how you should, like, the interview should be very specific for a specific program. That's my understanding from last year to this year. Like, the more you research the program, the better you do for the interview.
Yes. Hopefully we'll all, inshallah, succeed this year in the...
Good luck, Hiba. I mean, regardless, you are very professional, and your personality, enthusiasm, you are a perfect candidate. So you should be like, like confident about yourself.
Thank you. Thank you for this words. I really appreciate it. It just makes me strong from inside.
Oh, of course. Imagine, like, as I'm telling you, all of us here have a very unique things. You have like literally 3 continent experience. You have done all these exams. You are like, MPH, you are enrolled in MPH program. I don't know, like, like what qualification more than you need to do a residency. So just imagine that you are a very, very like, qualified candidate, and just, be confident. That's all you need now.
Thank you for this energetic words. I do really appreciate it. Thanks. Thanks, and Lubaba and everyone. So, Dr. Nader, we come to the end of...
Baba wants to share her experience also.
Yeah, so actually, I don't want to disencourage people from practice, but from my opinion, I practice a lot and I performed during the interview really different. And so as Sume mentioned, there is a lot of questions really unexpected. For example, for me, I always tell people tie every question to the program, and I was like preparing to end my tell me about myself. I am here to continue my learning journey at your blah blah program, stuff like that. But one of the attending, for example, when I joined the room, she was kind of smiling and happy, and she was like, I just read your personal statement, and I imagined my personal statement starting with a story. And she was like, and I imagined your kids and you are a mom. So all of the preparation that I made, I always shifted from it, and I was myself speaking to her. So that's why I'm like really hesitant to tell you, like, guard yourself during the interview, because you might find someone drag you to your genuine self, and you're going to be speaking and they will find out you are two different people. For Hiba, for example, because I felt that you are acting today because I know you. So it's not, so always be prepared. Like, the interview might not go like, tell me about yourself. I had an interview with a program director, did not ask me anything, any question. She was telling me her stories, and it was actually chatting. And basically, I had to ask her if I am able to ask her a question. And I asked her a question, and she answered. And I was like hoping that she would remember me from the person that asked a question. But so that I'm just trying to tell you that be prepared for all of the situation, to be professional, to be yourself, to be talking about your personal life too much, and try always just connect with the interviewer. So
Yeah.
as far as the questions, those are the one that we practice for them. So you will be asked about your strengths in maybe different ways. Tell me about 3 words, describe yourself and why. For example, they will ask you, maybe this is, I found a really maybe new question for me to come across, is like, what kind of faculties do you look for? And what rotation resonate with you, for example. So you will try your best to tie it for your, I think for you will be like, try your best to tie it to psychiatry. Whatever rotation that interested you, you will forget it and tell them about psychiatry, for example. This is what I did for this question, internal medicine and why internal medicine and stuff like that. So, but other than that, actually, I think the tension and how it is virtual, and you were thinking about eye contact or seeing the expression in the interviewer face, kind of confusing, and a lot of things are going on, as Somi mentioned. I think maybe we need just to prepare for that element, but try your best to be yourself and be comfortable and confident. Whatever answer you talk about, try to be really confident about it. And I think they will believe whatever you say. But other than that, I really felt like that was really very stressful. Prepare your coffee, your water, snack. It's sometimes a really long day, and try to interact with the residents as well. If there is a resident like meeting within the interview itself. So for my experience, they were resident, and you will be joining another room for a PD or associated program director or coordinator, for example. But you will be the whole time camera on with the resident. Maybe you will get like 5 minutes or 10 minutes break. 5 minutes both time. So I found it really very stressful, because you will be like opening the camera and try your best to be relaxed and be yourself, and be prepared for the unexpected questions. I think that's all, but if you have any specific question, I'll be happy to answer and help. And good luck for everyone.
Yeah, thank you, Lubaba. It's really tricky. But just the practice make you more confident in generating ideas. That's the point of practicing, is to be able to generate idea when you're running out of ideas.
I agree with you. But I found for myself, when I practice too much, because I said the answer too many times, when it is the actual time to say the answer, I forgot many points. So this is for my experience. But yeah, everyone is different. I agree with you. Like practice you will be comfortable in the camera and the new situation that you're having, building confidence when you're talking many times. But for my experience, I forgot a lot of things that I prepared. But
yeah, I'm definitely sure that you will be linked somewhere. It's about chemistry. Sometimes it's not just about putting answer in certain way. It's just about also, as you mentioned, for me today, I look worried because this chemistry between me and my other colleagues is not there, even though I wasn't like prepared like now, but there is some chemistry between me and you and some connection. So that's, I think, also a part that we need to focus on. And as you mentioned, we have to link ourselves with the speaker by certain thing.
Exactly.
Go ahead, Sumi.
Yeah, I would suggest, I agree with Lubaba, and basically me and Lubaba practiced a lot together. So, we know about ourselves, our CV and whatnot, our personality. So, what I found is same as well. I think Dr. Avinash, I did mock interview last week, right? So as I practiced a lot and whatnot, I mean, not a lot, but we practiced a significant, I would say like a decent amount of time. So that makes me like the questions are already, the answers I already know, but I already prepared for that question answer, but we still have to act, right, that we are doing. So that is one thing also I faced. And also, as Lubaba said, I'm like rephrasing my sentences, rethinking about my answers, and all that. So it's like sometimes what happened when the real interview came, basically you try to re-memorize those things. So what happened, like you may miss the main concept of it like too much. Instead, I would suggest you, I think it is better, what I found for myself, practicing, instead of practicing with other person, you practice on your own with a Zoom camera, and just record it, and like after recording, just hear about your own, what you think about yourself or your conversation, or there are some word or some manners you are using, or your lack, like your hand gestures or something, and try to fix that, I think. And how is your eye contact, something like that, instead of practicing with someone else. I think that is also a good thing, we should prepare for both way, but this is also, I think that things will work better, because I think you are not in a situation now that you need someone's feedback. That part is over. So now you correct on your own things, and like video record and then do it. Because I felt the same way what Lubaba felt. That's why I stopped practicing 2 days before, and I stopped thinking about my answers, because some of the answers it has to from your is a spontaneous answer, and it should have come from your mind or your brain instantly, right? Like say, like I some hobbies or something that we are discussing about with the resident physician and whatnot, and then I said like, oh, I recently ran 10K, and I want to run half marathon in future. And then one of the resident physicians said, oh, then if there is a blue code in during residency, you will be the one who will reach fast. So because you ran, so that is good, because sometimes like we hear and we become very sluggish to go there, something like that. So you are a runner, so it will be helpful for you. So you don't know how they will react, right? Because those are the answer when we practice. I keep like hearing from Lubaba or Sarah or someone else, and I know the answer will like, probably the answer or the response will be like that, but it is different in reality. It's like a kind of a drama, the way now I understand like how difficult face like being a profession like an actor. It's hard. So I just suggest you like it's better to practice on your end and like be yourself. That is more than anything, I think. And you're all set, and good luck everyone.
Thank you, Shalini. Thank you. I think we are in the end of our meeting. Dr. Nader, the last say for you. And thank you everyone for your contribution.
Thank you once again, everyone. Thank you, Hiba, and I wish you all the best, and everyone else, I wish you all the best. Good luck with your interviews, and good luck with your projects and ideas. So maybe we can, if you have a minute, or if you want to take a break, Hiba, I can come back after a couple of minutes after the meeting. The same meeting, this one. I'll be on hold for you.
No, I can continue with you after, if you don't mind.
Yeah, this is what I'm saying. Okay. For others, thank you so much for joining the meeting, and thank you for your hard work and your preparation for the interviews. I wish you all the best, and hopefully we will hear some good news from everyone for this year. Have a wonderful day. Thank you, Dr. Mazin, for leading the team at the Zoom meeting. Thanks.
Thank you so much.
Thank you, everyone. Have a wonderful day. Have a wonderful night and evening.
Have a wonderful day, everyone. Merry Christmas.
To you too.
So we will not meet next week. We will meet the week after, January 8th.
Oh, okay. Thank you.
Okay. Thank you, guys. If you can pass this to the others, that would be great.
Sure. I will pass to my team probably.
Thank you. And let me know the Orange team leader if you have a chance. Thank you.
Is it like Khalid Osman by any chance? Ali?
He was leader for some time, but because of situation in Sudan, I think maybe someone else. I'm not sure. If you can just pass it to the team,
Yeah, sure.
they can figure it out.
Contact even Khalid Osman. I have a contact with him like a couple days ago about the interview and whatnot. So I can ask him. Like probably he might know this.
Sounds good. Thank you so much, sir.
Thank you, Dr. Nadir and everyone. Have a good day.
Have a great day. Thanks. Bye-bye.
Thank you.
Thank you, everyone.
Thank you, Dr. Nadir.
Thank you, Dr. Ala. The rest. So, Hiba, you mentioned about the idea. So exactly your idea is to look at opioid use.
The hard drugs, yeah, and the hard drugs, the methamphetamine, cocaine, and opioid, if it's prescription or not. And I want to exclude the what they call it, cannabis and the alcohols from the illicit drug as an addiction.
Okay, it's a good idea. So what usually we start with is the question, like the research question, and the more specific you are, the better you will get the project running, and the idea can turn into something useful. If you want, you can replicate the idea with different concept, with the same concept with different wording. For instance, you can focus only on cannabinoids or the marijuana in older adults, and then look at the literature and then see what effect you want to see, what use, whatever the question. If you want, you can apply it this way. So the keywords will be older adults, cannabinoids, and then the use or whatever prevalence or whatever you want to put in your question. You can apply the same but change cannabinoid or the marijuana into what else you want to, let's say.
I want to assess the methamphetamine because this is
methamphetamine
and the heroin and the cocaine. So this is.
So you can use these three in one group, for instance. So you can term if there is a term, let's say hard substances or addictive substances or whatever, then you can look at this. So you will just reduce instead of, because if you want to make your question with all of them together, I think it will be you're spreading yourself thin, and it will not be, you think about acceptability from the other end, where you want to send it to for conference or as abstract, or if you want to write it a manuscript, what article or journal you want to submit to. So if you are specific, you have high chance of getting your idea together and your project together, and you can find something and it will be acceptable on the other side. If you go just spread, it will not go further than that. First of all, it will be too much work. Second of all, the point of interest for this group, the conference or whatever, they will not look at you compared to others as favorable. For instance, when we started the fellowship, Sumi, I think her idea was to focus on COVID. That was early on. And she wants to see all the characteristics of COVID and the population and older adults and the disease that comes. So I told her we can get the information from the record. It's easier because the hospital we work with, all electronic. So we'll just put numbers and run query. We will get an Excel sheet with all the information. But for the conference to get it sent to them and be accepted, we told her to condense, focus on certain areas. So we created 2 abstracts of the data, one for the cardiovascular. So that means the heart disease, just AFib, congestive heart failure, coronary artery disease, something like that, in one abstract.
Mhm.
Do you get what I mean?
Yes,
And
definitely.
then the rest of the other chronic kidney disease, whatever, rheumatoid or whatever, we put them into a separate group, a separate abstract, and we put it in a different term or title and submit it. So we ended up using 2 abstracts.
Okay.
The same data.
So just not to spread our idea and make it conclusive, just only to one idea, assessing one idea. Okay.
Yeah, one let's say one subtract, substance.
Answering one
One
questions
substance,
about
one
system.
category, or
Yeah.
If you want to apply the same concept to other substances, yes, we can do that, and we can end up with 2, 3, 4 abstracts, each with the title more or less similar, but focusing on one substance. Let's say, because
As
you
a
can
matter
talk about
okay, sorry for
alcohol, for instance, but if you want to talk about alcohol by itself, this separate. If you want to add it to all this, it will be too much.
Yeah, that will do some bias, I may think, to our result. So I want to focus just on the hard drugs, the street drugs, I will name it, because that's what I want to assess, because the population I'm focusing in, the elderly who get affected because some of them lose their house, their family, and
Sorry, my daughter was sign language with me, so sorry.
Okay, that's good. So my main it's the project come to my mind first is I wanted a quality improvement, but that will be very hard because the IRB approval, it may be challenging. I don't have any experience. Do you have any experience with the IRB?
So the IRB, yeah, I have a couple of projects went through the IRB. Actually, my first one, that was about 10 years ago. I went through the IRB approval process at that time, and then I knew the process. It can be straightforward, it can be challenging and long. So it depends on how clear your idea and what's the risk involved. So if you can identify these 2, then the process will be easily done.
So my first idea come to me when I wanted qualitative. I want to assess the risk factor for elderly abuse and defined by elderly abuse more than 60 years and above, and first time using hard drugs, street drugs. Let's name it this way.
Sorry, I think we are combining. So maybe I just want to clarify. You are talking about elder abuse, and then you are talking about the
drugs
use
is
of street. Who
drugs
are using the street drugs? Is it the
elderly
or
the elderly population above 60 years? That's my pain point, because no one highlight. I try to find some literature about the drugs abuse for elderly for the first time. Not I want to assess the risk factors, and I want to see like risk factors and what prevention measures do they provide for these elderly populations particularly, and what recommendation I want to put. So to do these elements, I need qualitative, and qualitative, it's mean questionnaire, which is need IRB approval. So I may switch to systemic review if I find the literature.
That's another option. Yes, I think that's might be the first step if you want to do it that way. And I think it's the shortest way. Maybe you can start that with some keywords.
First time abuse.
Yeah.
Above 60 years.
Above 60 years. See what you can find in the literature. And then if you find an article, you go to the references in that article, and then you go from there. So just see how many articles you can get and see it. And then we can talk about what you found. If you can find something, then you start from there, and I think it's easier, straightforward from there.
Okay. Okay.
If you can't, then we will talk about what the next step, the longer way.
The IRB. Okay, so thank you, Dr. Nader. That's my idea, because I see this particular population above 60. No one cares about their first time abuse of the street, and it's really evident in the street. And this is the first time, because he lost everything. He found himself in the street, and so patient client, I would say, they will use the mess to stay awake the whole night to protect themselves. So they go in the circle of addiction, and no support, no assessing. And this population, when they commit suicide, they don't play.
Yeah,
they mean it.
Sure. Yeah.
So I want to. This really something I'm very passionate about. You can see.
Sounds good. Yeah.
Thank you, Dr. Nader, for your listening, and I will definitely find, and I will keep you updated with me.
Sounds good. Thank you so much.
Thank you for your time. Thank you. Bye bye.
Yeah. Bye. Bye.
Happy New Year.
Same to you.
Thank you. Bye.
Assalamu alaikum, Dr. Sama. Dr. Sama. Assalamu alaikum.
Alaikum assalam, Dr. Nader. How are you?
Very good. Alhamdulillah. How are you?
Alhamdulillah, I'm good, Dr. Nader. Thank you
Good.
for this session. Assalamu alaikum.
Alaikum assalam wa rahmatullahi wa barakatuh. Assalamu alaikum.